Okay, I don't think that anyone can see me. Can anyone see me?
We can see you.
Oh, okay, great. I can't see me, so it's good that you all can see me. So I'll just go ahead and get started. I understand that someone's going to advance the slides for me. My name is Dr. Ayer Cole. I am an adult hematology oncology doctor from Tampa, Florida. I trained at Emory University and worked in the Grady Memorial Hospital Sickle Cell Center there as a resident and as a fellow. Learned to love to take care of sickle cell patients at Emory. I was very surprised when I came to Pinellas County, or to Hillsborough County, to find that there was a shortage of doctors who take care of sickle cell. And I've been taking care of sickle cell patients in Hillsborough County since 2004. I take care of over 100 sickle cell patients, and I absolutely love it. It's the thing that I like best in my practice. I do all of hematology and oncology, but the thing that I like best is taking care of sickle cell. And I'm very excited to say that we've seen a lot of advances in the last several years in sickle cell disease. And I've seen our patients living longer and longer and better and better. And so I'm always excited for a chance to share. One of the main reasons why I wanted to give this talk on this topic today, though, is because I do see a lot of patients who come to my office from other practices who are not on any appropriate therapies for sickle cell, except maybe folic acid and maybe HYDREA. And there are advances in sickle cell care that they're not taking advantage of, and that maybe their doctors don't know about it, or they haven't yet been convinced that it might be helpful to them. But I'm here today to help make sure that you all understand that there are new treatments for sickle cell and that you can live longer and better with these therapies. Can you advance the slide, please? Thank you. So just to review, I'm not going to try to focus a lot on the pathophysiology and the history of sickle cell disease, because that's not what this talk is about. But just to review, in case anybody is new to the topic, sickle cell disease is an inherited blood cell disorder. In order to have sickle cell disease, you'd have to get an abnormal gene from a mom and another one from a dad. And in the sickle cell disease, we have cells that are not healthy. They are genetically different, and as a result, they have a harder time moving through blood vessels. And the job of the red blood cell is to carry cells from the lungs to the tissues to deliver oxygen to all parts of the body. And the result of not getting enough oxygen to the tissues in the body is pain and organ dysfunction. So this is what we're dealing with sickle cell disease. We're dealing with unhealthy blood cells that die early, that cause pain, and don't service the tissues as they should. Can you advance, please? So sickle cell disease affects millions of people throughout the world. It affects 100,000 people in the United States. And interestingly enough, the state of Florida is one of the highest populations of sickle cell, has one of the highest populations of sickle cell disease in this country. The life expectancy for sickle cell patients is currently predicted to be in the late 40s. However, we're seeing with our patients with excellent sickle cell care that these patients are living longer and longer. So hope is on the way. Can you advance the slide, please? So again, this is an inherited disease that patients have since birth. You can't catch the sickle cell disease. You have to have two abnormal genes, one from each parent. There are different types of sickle cell disease that depend on the types of cells that types of abnormal genes that the patients inherit. There are more severe types of sickle cell disease, such as hemoglobin SS, and less severe hemoglobin, such as hemoglobin SC. And what we see as far as symptoms and signs of the disease somewhat depend on those genetics. Sickle cell disease can be diagnosed at birth with a simple blood test. And in the United States, it's required that blood test is done in every child that's born, regardless of ethnicity. The early diagnosis of sickle cell is crucial, and it has increased the life expectancy of patients with sickle cell. Can we advance, please? So patients with sickle cell have their earliest illness around the age of around the age of 5 months to 2 years, at which point sickle cell patients tend to have their first pain episode, which often results in swelling in the legs and the hands, and fuzziness and other symptoms. After that, patients may have sickle cell crisis, what we call sickle cell crisis or sickle cell pain episodes at varying intervals depending on the severity of the disease. Pain is the #1 complication of sickle cell disease, and it's the #1 reason why patients go to the emergency room. However, sickle cell disease is a multi-system disease, so in addition to pain, it causes other types of organ dysfunction and other types of symptoms, such as anemia and decreased immune or immune deficiency. You can advance the slide, please. So here's some examples of things that sickle cell also causes in addition to pain: anemia, infection, stroke, blindness, hearing loss, heart disease, lung disease, liver disease, joint disease, leg ulcers, and kidney failure. So oftentimes we are often addressing pain, but we need to address and prevent these other complications of sickle cell. Especially as an adult doctor, we see that these things are manifested in adults and become a large portion of our care. You can move on to the next slide. So my topic was developing a plan of care, and I decided to choose that topic because I feel like a lot of people don't have a plan of care. A lot of people are putting band-aids on the disease with pain medications and frequent hospitalizations, but no real effort to address and prevent acute and long-term complications of sickle cell disease. In addition to pain management, patients with sickle cell need disease-modifying therapies. These are therapies that prevent the disease from causing long-term complications and prevent early death. We can move on to the next slide. So things that we need to consider when developing a care plan include frequency and severity of pain. Not all sickle cell patients are the same. Some patients have pain rarely, some patients have pain every day. So we need to think about that in deciding which medications and what treatments would best serve which patients. We also need to think about frequency of hospitalizations. Some patients have chronic pain that plagues them every day, but are rarely in the hospital, and other patients are in the hospital several times a month. We also need to look at long-term complications of sickle cell disease. We need to address prevention of strokes, kidney disease, lung disease, such as pulmonary hypertension. We need to treat things such as ulcers, secondary sickle cell, and priapism. Comorbid conditions, we need to recognize that sickle cell patients don't just have sickle cell. Some of them have diabetes. Some of them have other diseases such as kidney disease, seizures, HIV even. We need to look at these other comorbid conditions and be able to determine how therapies affect those conditions or prevent those conditions as well. And then we also need to look at personal preferences. We need to look at patients' desires, wants, goals, and figure out how our treatment plans fit into the preferences of the patients that we're serving. One size definitely does not fit all. Can we advance, please? So use of pain medications. Again, patients with sickle cell have severe pain, and some of them have it every day, some of them have it once a month, some of them have it much less frequently. The sickest sickle cell patients as adults may have pain every day. Chronic pain in addition to what we would consider to be acute crisis pain, the type of pain that sends patients to the hospital. Unfortunately, though, a lot of times all we do is treat pain. We mask the sickle cell symptoms, which may help prevent patients from going into a full-blown crisis. However, we don't do preventative medicine, preventative sickle cell medicine a lot of times in sickle cell patients. And so we don't prevent complications like leg ulcers, strokes, renal failure, pulmonary disease. Pain medications aren't going to improve longevity. They're a temporary fix. Please advance. So we have lots of new therapies, however, for sickle cell disease, things that may improve quality of life, things that may decrease long-term complications, medications that may increase or decrease sickle cell crises. And we need to, as physicians, we need to make sure that we offer these medications in addition to pain medications so that we can actually decrease the complications of sickle cell and improve outcomes. So in using these new therapies, we have to, again, balance things like risk and benefits. We have to make sure that the medications that we're giving are making quality of life better without causing extensive side effects. And we need to make sure that we don't start a bunch of therapies at one time, but that we stagger them so that we can evaluate the benefit of the treatment as well as the negative outcomes. Physicians need to also be available to help and assist with getting access to these medications, many of which are expensive and may not be available in the local pharmacy. Please advance. So here's a list of sickle cell treatments that are currently available. Again, this is outside of pain medicines. We recognize the importance of pain medicines, but these are medications that actually can modify the course of the disease, change the symptoms of the disease, and prevent crises. Included in these diseases, these medications, one of the oldest being folic acid, is just a vitamin. Then we have HYDREA, XJade, also Jade New, NDARI, DAKVEO, and XBRYTA. We can go on to the next slide. So starting out with more traditional sickle cell disease therapies, you can advance. Folic acid. Please advance to the slide on folic acid. Thank you. So folic acid is one of the oldest treatments for sickle cell disease. It's mainly to help prevent the anemia associated with sickle cell disease. Patients with sickle cell have breakdown of blood cells. It's caused by the disease that causes increasing anemia. Normal hemoglobin in a non-sickle cell patient may be between 12 and 14. In a sickle cell patient, may be as low as 6. The constant breakdown of cells, what we call hemolysis, is hypothesized to require more folic acid to help build up and replenish the cells. So most patients with sickle cell should be taking folic acid. Some people take it over the counter. Other people take prescription strength. The recommended strength is 1 milligram a day, which is a prescription drug. Okay, we can advance. Next drug used for sickle cell, again, these are older drugs, YDROXYUREA. YDROXYUREA was approved in 1998. This is one of the oldest drugs for sickle cell. Most people with sickle cell have heard of this drug, but many people are still not on it. It's definitely underutilized in the adult community, probably utilized better in the pediatric community. YDROXYUREA works by increasing the fetal hemoglobin in patients with sickle cell. Fetal hemoglobin is what prevents babies from sickling until they hit that age in which the fetal hemoglobin drops. The fetal hemoglobin usually drops around age 2, at which point the babies make mostly adult hemoglobin. Fetal hemoglobin actually blocks sickling in patients with sickle cell disease. And by increasing fetal hemoglobin, we can decrease sickle cell crisis. HYDREA is the only drug known to increase the amount of time that people with sickle cell live. It prevents pain crisis, it prevents acute chest syndrome, strokes, and other organ damage. HYDREA is a very important building block to a sickle cell disease care plan. It should be used in most people who have 3 or more crises a year, or who have severe organ damage from sickle cell disease. HYDREA, however, is often underutilized because a lot of patients with sickle cell disease who are offered the disease have been taking it since their youth, and many people have decided that it doesn't work. However, I think that a lot of times we don't really realize how much it is actually doing. So it should be utilized in patients who have 3 more crises a year and people who have organ damage from sickle cell. And keep in mind, again, that it's the only medication that has been proven to prevent or to increase the amount of time with sickle cell that people with sickle cell disease live. We can go on to the next slide. So standard indications for sickle cell, again, frequent pain crises, acute chest syndrome, severe symptomatic anemia, severe complications from sickle cell disease, and pediatrics will use it in people with abnormal transcranial Dopplers. We don't do transcranial Dopplers in adults. And also we have found in recent studies that HYDREA can decrease strokes. And so it's recommended in people with strokes who are not willing or able to comply with a traditional transfusion program. Transfusion programs are the #1 treatment of stroke and sickle cell disease. We can go on to the next slide. So again, important to note, HYDREA is the only drug that has been shown to have a survival benefit for sickle cell. Newer drugs might have a survival benefit, but none of them have been tested long enough to see. So we can't rely on the newer drugs for survival benefits. So when we go on to newer drugs, I want you to keep in mind that all of the newer drugs have been tested in combination with HYDREA. And it's important to know this because I often see patients just stop HYDREA when they get offered newer drugs. And I always try to tell them that it's not really a substitute. If we have a drug that we know will help you to live longer, we should definitely try to keep that going, even though new things have come up, have been found to be effective as well. Okay, we can move on. Iron chelators. These, again, we're talking about drugs that modify the disease course of sickle cell. Not all these drugs are to treat sickle cell pain or to prevent crisis. Iron chelators have been around for many years, the oldest one being Desferal. The reason why we use iron chelators is because transfusions from sickle cell disease cause iron overload, and iron overload causes damage to organs, including the heart, the liver, and the tissues. And so most people with sickle cell disease who've been transfused more than 10 units of blood need to make sure that they don't have iron overload. And the treatments for iron overload are listed here. And anybody who has a ferritin of greater than 1,000 should be on an iron chelator. This is, again, a big gap I see in sickle cell care even today, that I see patients all the time who come to my office who've been seen by other hematology and oncology doctors in the community who are not on an iron chelator. And so, again, they don't decrease sickle cell pain, but they do modify the disease. They prevent the long-term complications of transfusion, iron overload specifically. We can go on to the next slide. And now we're going to address some new drug therapies. Okay, next slide. So first one, NDARI. NDARI is probably my favorite drug. I always tell people that it's my favorite drug because this drug has been approved since 2017. It's the first new therapy that was approved in 20 years since HYDREA. And first real drug to decrease sickle cell pain crisis, that is, because we do have the chelators that have come about since then as well. But this drug decreases sickle cell pain crisis. And this drug for me is my favorite because it's not as expensive as some of the other drugs, but it really does work and has low side effects. And our patients that I've seen since we started giving out NDARI in 2000, I think it's probably about 2018 when we first gave it, but the patients who we've put on NDARI decreased their crises very significantly. Prior to having NDARI available to our practice, we used to have about 10 patients in the hospital at all times. Once we started NDARI, we went down to probably about 3. NDARI is a powder that you mix with fluid and you drink it twice a day. And it decreases sickle cell crisis. It's been documented in clinical trials to decrease sickle cell crisis significantly. And I've seen that again in my practice. Some people don't like drugs that you have to drink. So sometimes that is a downside. And with the drugs like with NDARI, so much of many other sickle cell drugs, you have some GI side effects that sometimes it can irritate the abdomen. So we recommend taking the NDARI with food if it causes any kind of GI side effects, and it can also be mixed in food instead of taken in fluid. So NDARI is a wonderful drug. It does decrease crisis. It has been proven in medical research to decrease crisis, and I've seen it significantly in my office, that I've seen people go from being in a hospital every month to being in the hospital once in a couple of years. And I've seen people not be able to work and not be able to live normal lives, go back to living a normal life. This is a drug, it's a specialty drug. It has to come from a specialty pharmacy. And so you do need, in most cases, an oncology doctor or someone who knows how to order this drug in order to get this drug approved. And again, it does have low side effects outside of the GI realm. Let's go on to the next slide, please. Next drug I'll talk about is a DAKVEO. We use this drug frequently in our office as well. Also known as crizolizumab. It's a monoclonal antibody, very fancy type of drug that's given by IV. It's been proven to decrease sickle cell crises. It has to be infused every month. Initially, it's given bi-weekly, but then once a month. It's very convenient in that you don't have to take it every day. On the other hand, you do have to come to the office and have it infused. And for that reason, in most cases, you're going to need a hematology oncology doctor in order to give that medication. The benefit of a DAKVEO, again, is that it decreases crises. In the studies, patients who were on a DAKVEO had half as many sickle cell crises as those who didn't. And again, just like NDARI, a DAKVEO can be used with or without HYDREA. So you shouldn't stop hydroxyurea in order to take these drugs. Again, as I mentioned before, none of these drugs have been proven to have a survival benefit at this point outside of hydroxyurea. None of these drugs have been in existence long enough to prove that they have a survival benefit. So we may find that they do, but I wouldn't stop HYDREA to take the newer drugs. I would add it to the newer drugs if possible. DAKVEO is approved for patients age greater than 16 and older. We, in our practice, again, have used this drug, and we have had a number of patients who were really successful in this drug who used to be admitted to the hospital every month, who now have not been admitted for several months, even as much as a year since starting a DAKVEO. I do think that a DAKVEO is best for people who have frequent pain crises. I don't think that a DAKVEO is a medication that should be used just for people who have chronic pain. The advantage of the DAKVEO is it decreases pain crisis. It prevents hospitalizations. It shouldn't be used to prevent chronic pain in patients who are rarely hospitalized. You can go on to the next slide. Okay, so the next drug we're going to talk about is XBRYTA. It was kind of funny that XBRYTA was approved 10 days after DAKVEO. So we had no new drugs for years. HYDREA came out again decades ago. Then we had NDARI, I believe it was 2017, and then a DAKVEO in 2019, and then 10 days later we had XBRYTA. So that was kind of a whirlwind for me as somebody who was trying to figure out how to take care of patients with sickle cell disease with little or no resources for years. But XBRYTA is a great drug, but it's different than HYDREA. It's different than NDARI. It's different than DAKVEO in that the goal of XBRYTA is to decrease anemia. And so for years, you know, we lived with anemia in our sickle cell patients, and we didn't have any good treatment for it other than transfusions. But then XBRYTA came along, and the goal of XBRYTA is to decrease hemolysis, which is the breakdown of red blood cells, and to improve anemia specifically. So it's not we don't use it specifically for the purpose of managing pain, but for managing anemia. And so this was a new thing for me because I spent a lot of time managing pain and accepting the anemia. And then when XBRYTA came along, I realized that there was a large portion of patients who maybe don't complain that much of pain, but complain of chronic fatigue from sickle cell disease. And this medication is a great drug for those people. So I really look for patients who have more complaints of anemia and fatigue, less so of pain, for those who I really start XBRYTA on. And so those people tend to a lot of times be our healthier sickle cell patients. This drug is available for age 12 and older. So I mentioned before, our DAKVEO is for 16 and older. XBRYTA is for 12 and older. It's administered again as an oral medication. So a DAKVEO again was IV. This is this is oral. A DAKVEO is to decrease crises. This is to decrease anemia. So you can see how these drugs are different. They're not really interchangeable. Some patients might qualify for a DAKVEO and XBRYTA for different reasons. But usually I try to target, again, looking at patients' preferences, looking at what patients' biggest issues are, and choose the drugs accordingly. When I treat patients, I usually use HYDREA for anybody who has sickle cell disease and pain crises, preferably hemoglobin S beta thal and hemoglobin SS. Usually will use HYDREA for any of those patients. I usually will add on NDARI for anyone who is on HYDREA and still has pain. And then I look at a DAKVEO and XBRYTA for their merits. I add a DAKVEO for people who specifically are concerned about pain crisis, and XBRYTA for people who are specifically concerned about anemia and fatigue. The studies on XBRYTA show an increase of 1 gram or more in the group that received the XBRYTA medication. This medication, again, it's specifically tested for improving hemoglobin. It was not studied for decreasing crises. So we have to understand patients' priorities to figure out who would best benefit from this drug. But I do find that patients on XBRYTA report increased energy level, decreased fatigue, better quality of life. And I find that even if patients remain severely anemic, they feel less anemic on the XBRYTA. And I think that that's one of the benefits, is that they feel less anemic. And part of the reason for that might be the fact that XBRYTA improves the way the hemoglobin is delivered to the tissues. It improves the oxygen carrying capacity of the hemoglobin and improves the delivery to the tissues. So I really like XBRYTA as well. I use all 3 of these new drugs, NDARI, DAKVEO, and XBRYTA heavily in my office. And I also want to again remind you, I would not replace HYDREA with any of these drugs because HYDREA has a survival benefit. We should add on the other drugs for the merit of the other drugs, depending on patient preference. We can go on to the next slide. And lastly, I just wanted to add chronic blood transfusion. This is not a new medication, obviously. It's done probably less, but it is a therapy for sickle cell disease. Chronic blood transfusions are sometimes used in patients who have pain that doesn't improve with any of these medications. However, I think that nowadays, most patients can get improvement in pain with the use of these medications, and sometimes these medicines aren't tried. So I would always try the medications first if possible. But chronic blood transfusions are also sometimes utilized to prevent diseases such as strokes in patients who've had strokes previously. Sometimes they're used to help heal things like sickle cell leg ulcers. It can be very helpful with that. Also with things like priapism. People with chronic priapism sometimes benefit from chronic blood transfusion. However, I've also found benefit from both NDARI and DAKVEO in helping with chronic priapism, which is what we call an off-label use. It's not what the study was. It's not what was studied in those drugs. But you can use blood transfusions for those things as well. Blood transfusion is the one way to decrease chronic strokes. However, HYDREA have been found helpful to prevent strokes as well. We can go on to the next slide. And with chronic blood transfusion, you definitely have to worry again about iron overload. So we talked about the chelators on the other earlier, the desferal, the XJ, the JADNU. If you're on chronic blood transfusions, you need to be worried about chelating. Let's go on to the next slide. And so lastly, I want to talk very briefly about curative therapies for sickle cell disease. I'm not going to go into big details because I don't personally do these therapies, but I do refer people for these therapies. And I want to make sure that at the end of this talk, you have an idea of all of the things that you could potentially use in order to do better, to live better, to live longer with sickle cell disease. So bone marrow transplant is the only the only available curative treatment for sickle cell disease. Now, everybody asks about immune therapy with these new gene therapy, but gene therapy is not available to the general public. It's only a research tool, and it's not researched most places. Bone marrow transplant is available. It is available in the state of Florida. Even in Tampa, it's available at Moffitt Cancer Center. So bone marrow transplant is available. It's available for both pediatric patients and adults for sickle cell disease. It was just, it's been approved for pediatric patients for decades. It was just approved for adults within the last 10 years or so. And I have sent 2 patients for bone marrow transplant at Moffitt who were transplanted and cured. I'm often disappointed and sad that more people aren't interested in transplant, but I think that it's a scary thing for a lot of people with sickle cell disease. But people with sickle cell can go from living life with intermittent pain and crisis and hospitalizations and other complications to living a relatively normal life with the use of bone marrow transplant. So I do want to encourage more people to at least go for a transplant evaluation. So what is a bone marrow transplant? Well, bone marrow is the stuff that grows in the center of your bones. It's the stuff that comes out if you break a chicken bone in half. And that's where the early blood cells, from which all other cells come from. So it's like a bunch of seeds, and they grow repetitively throughout your lifespan, and they make more and more cells throughout your life. If you want to cure something such as sickle cell, one way to do that is to kill those seeds with chemotherapy, the seeds, again, that you yourself make normally as somebody with sickle cell, and replace them with seeds from somebody else. So a bone marrow transplant, you plant somebody else's bone marrow or your blood cell seeds into your bone marrow. Now that sounds really complicated, and it is because it requires high doses of chemotherapy to get rid of the cells within your bone marrow. And then it requires the bone marrow from someone else to be infused into your bloodstream. And once they infuse that, they infuse it just like they would give a blood transfusion. And once they infuse it, those cells are so smart that they know exactly where to go, and they go right to the bone marrow and they implant themselves. It's pretty genius that cells are able to do that. They implant themselves in the bone, in the center of the bones. They don't have to put them in the center of the bones. They go there by themselves, and then they grow and they replace the seeds that we got, or the stem cells that we got rid of. And by doing that, you go from somebody who has sickle cell disease to being somebody who does not. And so my patients with sickle cell, who had sickle cell disease, who've been transplanted, are amazed at what it's like to wake up every day without pain. They're amazed at what it's like not to have a sickle cell pain crisis, but they're just amazed at what it's like to wake up every day without pain. Because of the high doses of chemotherapy that have to be given in order to do a bone marrow transplant, and because of the fact that you need a donor that is able to donate for you, a lot of people are really hesitant to get the bone marrow transplants, and some people don't have appropriate donors. But nowadays, we are doing at Moffitt, they are doing, I should say, what we call haplotransplants, where the donor has to be can be a parent. Previously, you had to have a sibling, and that was one of the reasons why a lot of people didn't get transplanted, because you had to have a sibling to in order to get a transplant. But nowadays you can have a parent who is a half match and still have a transplant and be successful. And Moffitt has great outcomes for bone marrow transplants, as do other facilities that do bone marrow transplants. But for a long time in Florida specifically, we only had transplants available for pediatric patients, and now these are available for kids as well, for adults as well. So again, this is one of the last therapies that I always recommend. It's for people who are sicker, who have more complications from their sickle cell disease. For kids, they're recommending that more and more kids get transplanted earlier and earlier. But for adults, they tend to reserve them for the adults with the most complications for sickle cell disease. At least 3 crises a year, and maybe some crises or complications such as pulmonary hypertension or strokes and things like that. So this is available in our community. It's available in the state of Florida. And, I just want to make sure everybody knows about transplant, because it is a curative option for sickle cell disease. It is the only curative option that is generally available at this time. We can go on to the next slide. And then the last therapy here is gene therapy. And again, I put on gene therapy because everyone is always talking about gene therapy. And a lot of people want to wait for gene therapy. They don't want to do bone marrow transplant, but they say they're waiting for maybe gene therapy because it is a curative option for sickle cell disease, but it's still highly experimental. It's still an experiment at this time. People have been cured with the gene therapy, but it's not readily available. Moffitt, I know, plans to start doing gene therapy, but I'm not sure when that will be or who will be qualified. But gene therapy basically involves genetically altering the patient's own stem cells. Again, we talked about the fact that in the center of your bones, you have stem cells which grow like seeds and make new blood cells. They make red blood cells, they make white blood cells, they make platelets. Now, in gene therapy, they take those stem cells and they take your own stem cells and they edit them, they change them and make them and get rid of that sickle cell abnormal hemoglobin. And then they implant them using a virus vector. So what that means is, just like we catch any kind of virus, viruses are easily spread through our body. They use the envelope from the virus to carry that gene that they took out of you and they altered and they fixed, and then they give it back to the body. And then that virus implants and repopulates the bone marrow with healthy red blood cells. You can go on to the next slide. And then another type of gene therapy that they're looking at is specifically to improve, it's just to increase the fetal hemoglobin. So the first gene therapy we talked about gives you normal beta globin, which is the abnormality that we see in sickle cell disease. And then the second type of gene therapy that's being looked at is a type of gene therapy that aims to increase fetal hemoglobin. So there's something in us that makes us stop producing fetal hemoglobin when we hit the age of around 2. And this other type of gene therapy helps to turn that back on. We can go on to the next slide. All right, so I think that concludes my presentation for the day. But basically what again I want to would like you to take away from this talk again is that there are many different treatments for sickle cell disease, and they're often underutilized in our community, underutilized by our hematologists who should be offering them, as well as by our patients. And I just hope that this talk here helps you to realize that you could be living longer and better with an appropriate care plan, with appropriate sickle cell care. And that pain medication masking your pain is not the only way to treat sickle cell disease, but there are medications available that actually prevent pain and prevent anemia and prevent other symptoms of sickle cell disease. And definitely, if you have questions about those diseases, we are available. We do see patients by telemedicine throughout the state, and we're available to explain more to you about any of those diseases and help you to decide which of those. We're available to help you learn more about those treatments and help you to decide which of those might be available to you if you don't have someone to teach you about those treatments in your community. So I appreciate the time to be here today, and I think that we're supposed to have some time for questions and answers.
There are a couple of questions already in the chat. If you guys do have any questions, please put them in the chat below or on your WOVA app, and I'll be more than happy to read them out to our beautiful speaker today. First question we have today is how are you letting doctors that are not our primary care doctors know about our care plan, like this specific care plan?
Okay, so the question was, how am I letting people who are not primary care doctors know about by that, do you mean other specialists or?
I believe so, yes, ma'am.
That's a hard question. So I'm a private doctor, I'm in private medicine. So I do give talks on different sickle cell treatments from time to time, give talks to the community as well as to other medical providers about sickle cell treatment. But my focus is really on patients. It's not really so much on other doctors. I focus on teaching people with sickle cell how to live better with sickle cell and making sure that people with sickle cell have access to all of the latest treatments.
Right.
But I'm always available if anybody would like to have me give a talk about sickle cell. I do it free of charge. I do it because I love it.
Of course. Second question here. You mentioned that HYDROXYUREA is almost exclusively in patients with like SS. Is it open to other genotypes or is it just exclusively to? It
was initially approved for hemoglobin SS and hemoglobin S beta thal.
Okay.
Some people use it in people who have hemoglobin SC disease. I personally have not gotten into the habit of using it with people who have hemoglobin SC disease, because the initial therapy was proven for hemoglobin SS and hemoglobin S beta thal. So it's an off-label, what we call off-label, when you're doing something that hasn't been done in the studies. Specifically, I believe the studies that looked at stroke and sickle cell disease using HYDREA to prevent further strokes did include hemoglobin SC disease. So it can be used in those. The one problem with using HYDREA in people with hemoglobin SC disease is that people with hemoglobin SC disease tend to not be very anemic. They may not be anemic at all, and HYDREA actually increases the hemoglobin further, and making the hemoglobin too high increases the thickness of the blood and it increases the risk of stroke. So that would be my one concern about using HYDREA in people with hemoglobin SC disease. Generally, it's recommended for people who have 3 or more crises a year and complications, serious complications from sickle cell disease. People with hemoglobin SC disease may not have 3 or more crises a year.
Right.
So in those patients, one thing that I said repeatedly is that HYDREA is important because it increases survival. And people with hemoglobin SC disease already have an increased survival. So that's one thing, to consider. So you have to take each patient individually. I do have a few patients with hemoglobin SC who are on HYDREA. Usually they were started on it by somebody else and I continue it.
Okay, great. Couple more questions here. Another question asks, are you noticing that that your patients benefit from DAKVEO? Are more DAKVEO?
DAKVEO, okay, go ahead.
Yes. Are more than one genotype, like SC, and patients who benefit from XBRYTA are of a different genotype. So I guess are you seeing results in patients who are on the 2 different medicines?
Okay.
Genotypes? Yeah,
I would say that I do. DAKVEO and XBRYTA are both approved for all genotypes. So unlike HYDREA, which was only tested in hemoglobin S beta thal and hemoglobin SS, DAKVEO and XBRYTA were both tested in all genotypes, and none of them are excluded. So I use it in all genotypes, and I haven't really made an attempt to separate out the efficacy in one genotype versus the other. But I think that based upon the data, it should work in all genotypes.
Okay. Last question here. Why are chronically transfused patients not being exchange transfused in order to prevent iron overload?
I think that's an excellent question. And in my practice, anybody who's chronically transfused is exchange transfused. I only do exchange transfusions for people who are needing exchange transfusion programs. So I use exchange transfusions, again, sometimes for people who have pain crises very frequently that I just can't figure out any other way to stop. Usually I try the other medications first, but some people don't tolerate them for one reason or the other, or it just doesn't work. So I use exchange transfusions for people also who just prefer not to try medications to decrease crises. So I use it for those people. I use it for people who have priapism that's not controlled with other medications. And I use it for people who have strokes. And it is the #1 treatment. It's the standard of care for stroke prevention in people who've had strokes before. So I use it in all of those people. Now, not everybody has access to exchange transfusions. So in our county and in several other counties, the blood bank is able to come out and do the exchange transfusions for the entire county. They go to any hospital. Some hospitals have their own machines to do exchange transfusions. So it's done different ways in different places. But there are definitely places that don't do exchange transfusions at all, that the hospitals don't have the capability. And there's also people who maybe don't tolerate it for one reason or another. They don't tolerate the large volumes of blood and the shifts in what they perceive as a shift in their blood volume. So there are some people who don't tolerate it, because we do exchange a lot of blood. We use 10 units of blood in a lot of the patients. And some people have symptoms from that. Most people tolerate it pretty well. But so for those who can't have exchange transfusions, large volume exchange transfusions, sometimes what's done is you take off a couple units and then put on a couple units. And so that's another way, that's a kind of a cheap way to do an exchange transfusion is to take off 2 units and add 2 units. And what it does is it decreases the amount of sickle cells that you have without increasing the iron. So that's another option if you can't do an exchange transfusion, is it's what we call phlebotomy, is to take off a couple units of blood and give a couple units, as opposed to exchanging 10 units of blood, which requires a machine, and that's what makes it more difficult. So that can be done. In some places, people are just getting a unit of blood once a month. What happens with that is you get very heavy iron levels, or very high iron levels, and that causes iron overload, which, like I said before, it causes heart disease, liver disease, and other complications. So I think just giving a unit of blood once a month in the long run for most people is problematic. But if you do it, you have to use a chelator. You have to be taking something to bind the iron, such as desferol or XJADNU. Those are the ones we usually use now, XJADNU.
Okay. And there's actually another question that just popped up. Why use XBRYTA in SC patients if it increases hemoglobin? Is there any other medicines that will actually benefit better?
So for me, I wouldn't use XBRYTA in patients who are not anemic, but there are some hemoglobin SC patients who are very anemic. And for those patients, I would consider XBRYTA. People can be very anemic for a lot of different reasons. If you have hemoglobin SC disease, generally your hemoglobin would be between 10 and 13 or 14 even. But some people have kidney disease and other things that are bringing their hemoglobin down as well. And some people still wind up being pretty anemic with hemoglobin SC. I wouldn't use it though if you're not treating anemia, because it really is designed to treat anemia. It does help fatigue from anemia and helps the oxygen carrying capacity of the blood cell, but it's really specifically for anemia. So I agree, I wouldn't use it for somebody with hemoglobin SC disease unless that was the specific indication. For people with hemoglobin SC disease, they may still have pain. And if they have frequent pain crisis, I would put them on a DAKVEO. If they have frequent pain, but maybe not being admitted to the hospital all the time, not having frequent pain crises, I would definitely consider NDARI. So NDARI would be my first drug, probably in most hemoglobin SC disease patients. And then I would probably add a DAKVEO if they were still going to the hospital frequently.
Great. If there isn't any more questions, I will turn it back over to our wonderful host. Thank you, Doctor.
Okay, thank you. Appreciate it.
You're muted.
Thank you so much. Thank you so much, Dr. Cole. I appreciate you so much. This information was awesome. We definitely gained a lot of knowledge from your presentation, and great questions, audience. Thank you so much. We are going to move to the next session. If you have any more questions, you can always continue to put them in the chat, and we'll always be able to communicate with Dr. Cole in order for, we'll answer at least 2 questions. So thank you so much, and continue enjoying the symposium. We can move on to the next session.